Allergic diseases are most common worldwide, and there have been growing number of reports that the prevalence and severity of various allergy diseases have increased in the last 2 decades. It is estimated that about 20 to 30% of the world's population is affected by one or more form of allergy disease. The major portion of allergy practice is currently in the hands of dedicated allergy specialists. But all of us pulmonologists do deal with allergy in their clinical practice. Against these background, Indian Chest Society conceptualized a 4-part webinar series to cover various allergic topics. So friends, hello, I am Dr. Rajesh Swarnakar, Secretary of Indian Chest Society, welcoming you to part 3 of this web series modules on allergy and immunotherapy, brought to you in association with Sanofi India. In the part 1, which was streamed live on 25th February, we dealt with the key topics of discussion. On the first module was basic immunology related to allergy, aerobiology of outdoor allergens. We told you how to do allergy skin testing. We heard how in vitro tests for diagnosis of allergy are available, and we briefly touched on Alexis. In the part 2, which was streamed on 25th, and allergic AV diseases, we heard allergy and non-allergic rhinitis talks, rhinitis and asthma in children, in adults, also on occupational allergy and asthma. Those who have missed these 2 allergy modules can log in to the ICS educative volume on this YouTube, and they can retrieve this archived web series and hear to it. But as of now, we are here to deal with allergy immunotherapy module 3 or chapter 3 of this allergy immunotherapy module. And as always, we bring you interesting topics. So further to this module, today we are going to deal with urticaria and angioedema. Further, we are going to learn about insect venom allergy, and also hear talks on air pollution and allergic diseases, and deal with biologics in treatment of allergic diseases. And as always, we have, in a quest to bring the best experts, we've got 4 experts on who will deal with these topics. And I'm happy to introduce you to them. I should first welcome Dr. Shravani Ghosh Soha, who's MBBS, MD, PGI, Chandigarh, MRCP and FRCP from UK. She worked as specialist registrar, Royal Liverpool University Hospital in UK. She was ex-associate professor at WIMS. She's a reviewer of Indian Journal of Dermatology and Operatic Dermatology Journal, and is senior consultant dermatologist of Apollo Multi-Specialty Hospital, Kolkata. And today she will talk on angioedema and urticaria. Welcome, Dr. Shravani Ghosh Soha, in this web series. We have another expert for you today, Dr. Narvada Ashok, whom I am quite eager to welcome. She's a director and consultant pediatrician at Nalam Medical Center and Hospital, which is at Vellore in Tamil Nadu. And she will talk on insect venom allergy in this webinar. And friends, I'm quite happy to introduce our 2 veteran expert orators, Dr. Raja Adhar, who's Director of Department of Pulmonology, CMRI Hospital, Kolkata, He will speak on allergic disease and air pollution. And our own Dr. Deepak Talwar, who is Director of Pulmonology at Metro Hospital, Delhi, who will deal with biologicals in allergic asthma. The talk will be followed, as always, by a question and answer session, which would be chaired by Dr. Saibal Moitra, allergologist at Kolkata, and the person whose brain behind this whole fifth series and has put a lot of effort in conceptualizing and bringing it to you, the whole modules. So please do post your questions or queries after each lecture, and we'll try to address them to our expert today. For now, over to Dr. Shravani Ghosh Soya. The virtual stage is yours, ma'am, to deliver the talk on urticaria and angioedema. Thank you. Yes, Dr. Zoha, can we start?
Yeah, they've recorded. Could you please start the record, please? A very good evening to you all. I am Dr. Shravani Ghosh Zoha, Senior Consultant Dermatologist from Apollo Multispeciality Hospital, Kolkata. Today, I'm going to discuss a very common condition, urticaria, and not so uncommon condition, angioedema. But before I start, I must thank the organizer for giving me this opportunity to speak in this august forum. So, urticaria are hives. They're itchy, raised erythematous areas of skin, and it can start at any age without any warning. Angioedema is the swelling of the subcutaneous tissue, and which can present as painful swellings, and it can occur at any parts of body, including the respiratory tract, which can cause bronchospasm, and it can be dangerous at times. A large variety of urticaria and angioedema actually exists, and I would like to highlight the novel insights in the pathogenesis and the current guidelines of management of this condition. So, as I mentioned, urticaria is very common. It's present in 15 to 20% of the population at any time of their life. And acute urticaria is, of course, more common, and there's a female preponderance, and the usual peak is 20 to 40 years of age. If you see into this pie chart, you can see in 40% cases, urticaria can present alone. In 40% cases, there can be overlap of urticaria and angioedema. And in 20% cases, there can be just angioedema. So whenever a patient presents with these urticarial lesions, as a physician, you have to ask, how can I classify this lesion? You ask yourself, what could be the cause of this hive? Is there any medical condition or drugs that could contribute to these lesions? What tests should be done? And how best I can treat my patient? So to proceed, before you get the answer, you should know how you classify urticaria. If these lesions are persisting for more than 48 hours, you are dealing with urticarial vasculitis. But if the lesions are persisting less than 48 hours, you are dealing with a case of urticaria. Now, urticaria, we call it chronic urticaria when the duration of disease is more than 6 weeks, and we call it acute urticaria when the duration is less than 6 weeks. Mostly we are lucky in case of acute urticaria to find some precipitating cause, but we are not so lucky in case of chronic urticaria. Chronic urticaria can be divided as chronic spontaneous urticaria, chronic inducible urticaria, and sometimes there can be some other rare causes as well. So if you look into the causes, unfortunately, we deal with mostly these chronic urticaria patients, and mostly they are idiopathic. We are unable to find any cause for these lesions. And of course, you have to look for medications, any stings, foods that can cause any infection, Physical urticarias means physical factors can aggravate these urticarial lesions. And don't forget the rare causes like neoplasm, collagen vascular disease, endocrine causes, and arterial vasculitis. So coming to the pathogenesis, urticaria is mainly an immune-mediated inflammatory disease. We don't know the exact pathophysiology yet, but an autoimmune theory has been put forth in 30 to 50% cases of chronic urticaria. There are mast cells, eosinophils, endothelial cells, there's complement activation, coagulation abnormalities, mixed Th1, Th2 response, but the bottom line is it is a mast cell driven disease. So this is a schematic diagram. If you can see here, the extrinsic factors like food, stress, drugs, infection, physical causes can lead to mast cell degranulation. And humoral alterations like autoimmunity, autoallergy, complement activation, splenic tyrosine kinase factor signaling defect, they can all lead to signal, mast cell degranulation. And once they're degranulated, there's release of histamine, tryptase, nerve growth factor, prostaglandins. This nerve growth factor actually stimulates the sensory nerve ending, which gives rise to this intense pruritus in urticaria. And this histamine, prostaglandin, they cause vasodilatations and the other edema, erythema, the symptoms that we see in urticaria. So acute urticaria can be Ig mediated through the circulating antigens such as food, drugs, stings can use this mechanism. Then you can have non-immunologic release of histamine with acetylcholine, opiates, polymyxins, strawberries, NSAIDs, aspirin. Complement or immune complex mediated urticaria we can see with whole blood administration, plasma, immunoglobulins, drugs, insect stings, and so on. And of course, in chronic urticaria, we are not so lucky. You can see in 53% of chronic urticaria, we say it's chronic spontaneous urticaria, unknown etiology. And in 23%, we have this chronic inducible urticaria where physical factors can be responsible to precipitate these lesions. And sometimes you can be lucky to find out that some causes like drugs, thyroid disease, foods, etc. can be associated with a certain percentage of cases of chronic urticaria. So this is what is CINDU or chronic inducible urticaria. So physical urticarias, a group of urticarias where mechanical, thermal, solar, etc. Radiation, etc. can cause urticarial lesions. And dermographism is the most common form. You must have come across patients who complain of these linear urticarial lesions on stroking. Do reassure your patients. Just looking at the dermographism, but by presence of dermographism does not warrant any treatment. If your patients are symptomatic, only then they need treatment. Otherwise, the patient should be reassured if they are not having symptoms. Then pressure urticaria, when you use a perpendicular pressure, that can give rise to deep-seated urticarial swelling, which can be painful at times. We call this pressure urticaria. Now, cholinergic urticaria is a tricky situation where usually the heat, stress, exertion can increase the body temperature and give rise to this small urticaria, very discrete small urticarial lesions, very diagnostic of this cholinergic urticaria. This urticaria is a bit tricky because if this is present in sports persons where you can't give an antihistamine, especially this cholinergic urticaria responds very well to cyproheptadine. So in those sports person, you can't use this type 1 antihistamine because that is going to reduce the sporting capability. So sometimes it becomes tricky to manage this patients. And last but not the least is cold urticaria. Application of ice can reveal this urticarial lesions. So this is what we call cold urticaria. And do remember, cold urticaria can be associated with cold hemolysins or cold agglutinin disease. And what about urticaria will be incomplete these days without mention of COVID-19 infection, Actually, during this first wave, just looking at these articulated lesions, we have been able to suspect COVID-19 infections. There was such a spurt of this articulated lesions. So COVID-19 infection can give rise to urticaria, and it is thought that complement and mast cell activation happens due to direct cytopathic effect of the SARS virus, or it could be the cytokine signaling defect which leads to this urticarial lesions. And of course, during this pandemic, we have used lots and lots of drugs which could have given rise to this new onset urticarial reactions. And lastly, the vaccine induced urticaria, and JAMA Dermatology reported 1.9% of cases, especially with RNA vaccines, are shown to cause more this vaccine-induced urticaria. But fortunately, 83% of them were able to take the second vaccine without much problem. So management of urticaria involves diagnosis, identification of the causes, investigations, treatment, and last but not the least, patient support. So detailed history is the most important thing in diagnosing urticaria, because when the patient comes to you, they don't actually, they might not show the actual lesions. And so you have to ask the, how severe the disease is, the frequency, duration, presence of any other symptoms, family history. And we have to read drug history is very, very important, because most of the time patient forget whether any food is associated, and the quality of life impairment and the emotional impact it has on the patient. That is also very important, because we are going to decide, how much energetically you're going to treat your patients. And therapies that has been used and response to treatment is also important to determine what treatment you are going to give. So during evaluation, do evaluate about symptoms of anaphylaxis, breathing difficulties. General body examination is important. For acute urticaria, usually no testing is required. And remember, if your patient is presenting with urticaria and angioedema, you need not test C1 esterase deficiency, because that angioedema is histamine mediated, and there's no role of C1 esterase in such cases. So we don't need to test that. In most cases of chronic urticaria, as I already mentioned, mostly they are idiopathic, but if physical urticaria is suspected, a challenge test can be performed. Patients will often ask you about food allergies. They are not going to leave your chamber without asking what foods they're going to omit. So IgA-mediated food allergy is far more likely to be present in acute urticaria, whereas a detailed food diary or dietary modification may reveal that foods or additives can cause fluctuations in symptoms of chronic urticaria. So when you evaluate, as I mentioned, history and physical examination, then confirm the diagnosis. For acute urticaria, no laboratory test. For chronic urticaria, you might need to do a couple of tests. If the patient have atypical features, then skin biopsy, serum tryptase, complement levels, electrophoresis, antinuclear factor, those might be important. And autologous serum stimulation test, where we use serial dilutions of patient's own serum over the forum to see the positive flare reaction is considered as presence of circulating antibodies. So this can be done in case of autoimmune urticaria. And basophil activation test, basophils are involved in chronic urticaria, so quantification can be useful for screening in cases of autoimmune urticaria only. Now coming to the differential diagnosis, because not always diagnosing urticaria is that straightforward. It might be confused with arterial vasculitis, systemic mastocytosis, atopic dermatitis, non-bullous bullous pemphigoid, erythema multiforme, and some rare syndromes, familial cold autoinflammatory syndrome, Muckle-Wells syndrome, Stinsel syndrome, and so on. So in arterial vasculitis, the lesion will persist more than 48 hours. In systemic mastocytosis, usually the children present with this articulated lesions, and they should be hyperpigmented old lesions. And you all know about various signs. Stroking of the skin across the lesion will reveal an articarial line, which is known as JDS sign. So if you suspect that this your patient needs more investigations. And no, erythema multiforme non-bullous pemphigoid, honestly, sometimes it needs clinical expertise to diagnose these cases. The arterial vasculitis, here you can see the lesions are more profound, they leave pigmentations, they persist longer, they can be painful. So skin biopsy will be able to diagnose the perivascular infiltrations and diagnose arterial vasculitis. And bullous pemphigoid in early case, cases where the patient presents with intense itching and arterial lesions when the bulla is yet to develop, sometimes it might be very confusing, especially in elderly person if they are complaining of intense itch and arterial lesions which stays. So do consider this diagnosis and go for a skin biopsy, ask for a skin biopsy. So coming to the management, arterial non-drug therapy should involve general advice, remove identifiable cause and triggers, and diet exclusion diet and low pseudo-allergen diet can be considered. Now pseudo-allergen free diet means the diet which has low histamine content, mostly vegetables, meat, bread, pasta, dairy products, and actually this does not cause you any money, but sometimes that can be beneficial for the patient, so it's worth trying. Coming to the drug treatment, first line management is with second generation antihistamines if the symptoms are not controlled in 2 to 4 weeks, or if your patients are symptomatic, you can escalate the dose of antihistamines, you can do permutation and combination. And as a third line, the international guideline is omalizumab, but in our country, definitely this is not very much affordable. And the fourth line treatment is cyclosporine. In all cases, you can use a short period steroids if the symptoms are not controlled. The newer treatment of urticaria is of course omalizumab, which blocks this binding of Ig to the receptor. Previously, it was thought that ligelizumab have a more affinity than omalizumab, but now it has been proved that it doesn't have any benefit over omalizumab. Omalizumab for treatment of chronic idiopathic or spontaneous urticaria have been shown to be very effective. There are quite a few studies. The safety and effectiveness of omalizumab in pediatric patients population has also been established, and I'm sure all of you have more experience of using omalizumab in asthma than us. And unfortunately, there are patients who doesn't respond to omalizumab, especially patients who are overweight, who had used treated with cyclosporine, or patients who have low Ig. These are the patients who tend to be resistant with normal dose of omalizumab, and it has been found that updosing of omalizumab to 450 milligram or giving 300 milligram twice daily can actually give you the desired results. So it's worth doing if the patient can afford. And it is a reasonable safe drug other than hypersensory reactions, which you should monitor your patients up to 2 hours post injection. Apart from that, we didn't come across much side effects with this drug. And ligelizumab failed to show superiority to omalizumab in chronic urticaria. That's what they have announced after this Pearl 1 and Pearl 2 phase 3 studies. So they have withdrawn this product from the market, and now they have concentrated on a newer drug called remibrutinib. They are Bruton tyrosine kinase inhibitor. Remibrutinib is a highly selective inhibitor of Bruton kinase. This Bruton kinase and splenic tyrosine kinase, they are important for transmission of the signal in the intercellularly. So Bruton kinase inhibits this signal transduction, thereby inhibits this degranulation of the mast cells. So in future, hopefully we will have another drug in our basket which can help us in our therapeutic armamentarium of urticaria treatment. Now, coming to the second part, angioedema is defined as a vascular reaction of deep dermal subcutaneous tissues or mucosal submucosal tissues with increased permeability of blood vessels, resulting in tissue swelling. So angioedema is the swelling in the deep layers of the skin, and it can be accompanied with urticaria. Other symptoms include abdominal pain, shortness of breath, dizziness, and the commonly affected areas are oral mucosa, larynx, genitals, hands, feet. There can be abdominal swelling as well, and the patient usually complains of abdominal pain. So as you can see in this picture, there can be sometimes asymmetrical swelling of the face. This usually happens because the patient tends to lie on one side. That's why this asymmetrical edema usually happens. And so this edema, if there's edema of the floor of the mouth or oral mucosa, be very careful if the patient is going to develop any bronchospasm. So if we look into this epidemiology of urticaria, in 38%, angioedema, in 38%, it's because of unknown etiology. In 25%, C1 inhibitor deficiency or defect can be responsible. In 11% cases, ACE inhibitor is involved. So that's quite a chunk of the patients. And over last 10, 15 years, we have seen an increasing amount of angioedema with this ACE inhibitor therapy. And the rest can be some specific factors involved. So the clinical features, because of capillary leak, there's urticaria, angioedema, laryngeal edema, there can be hypotension, syncope, due to smooth muscle contraction, you can have abdominal cramps, nausea, rhinitis, conjunctivitis, and because of mucosal secretion, they can develop bronchospasm and diarrhea. So if you look into the mechanism of angioedema, if it is mast cell mediated, there's release of histamine that can give to angioedema. But if it is kinin related, especially this high molecular weight kinins, this kallikrein degrades this high molecular weight kinin to bradykinin. And do remember, this C1 inhibitor is responsible for conversion of pre-kallikrein to kallikrein. So if there is deficiency of the C1 esterase inhibitor, then there's more accumulation of there's more stimulation of this bradykinin formation, and the patient can develop angioedema. Now this bradykinin binds to the receptor B2 receptor in order to cause vasodilatation, and icatibant is a new drug which blocks this receptor and thereby action of this bradykinin. And here you can see bradykinin is degraded to inactive metabolites with the help of ACE enzyme. So ACE inhibitor, when it inhibits this this enzyme, there is more accumulation of bradykinin, and that can give to angioedematous lesion. And ecallantide is another drug which blocks this kallikrein, and that can be helpful in treatment of angioedema. So if you look into the patients, you do suspect histamine-mediated angioedema when they have urticaria, itching, rapid onset of symptoms, response to epinephrine is better, patients present with hypotension, shock, wheeze, then do think of histamine-mediated angioedema. And with bradykinin mediated, when there's swelling of lips, tongues, laryngeal swelling, facial swelling, abdominal swelling, peripheral swelling, genitourinary swelling, think of bradykinin mediated angioedema. And so these features are important because that will help you to determine what treatment you're going to opt. So this is, here I tried to classify angioedema. If bradykinin-induced angioedema can be C1 inhibitor deficient or defective, or there can be C1 inhibitor normal, as we see in ACE-induced angioedema, or there can be gene mutation of factor 12 enzymes, which can lead to this. This is also known as hereditary angioedema type 3. Usually this type of angioedema is seen in pregnant or in patients who are having oral contraceptives. They can have this kind of angioedema. And Hereditary angioedema, inherited variety, can be 1 or 2 depending on the deficiency or defective enzymes. And this acquired kind can be because of some lymphoproliferative disorder, some autoimmune disease, you can have this acquired kind of C1 inhibitor defect. And of course, mast cell can be Ig mediated, non-Ig mediated, and there is a small portion of idiopathic angioedema. And another point I forgot to mention, that we do see angioedema with tissue plasminogen activator therapy. Recently, they use this for this treatment of ischemic stroke, and it is thought that this tissue plasminogen activator, they activate the histamine release and also plasma mediated release of bradykinin, thereby causing angioedematous lesion. So if your patient is having a recombinant tissue plasminogen activator, be careful of development of angioedema. So when to suspect hereditary angioedema? If the patient have history of recurrent angioedema, family history, onset in early childhood, the complaints of recurrent painful abdominal, recurrent painful lesions and abdominal symptoms, upper airway edema, fail to respond to glucocorticoid, antihistamines, epinephrine, presence of prodromal symptoms, absence of urticaria, all this will point towards hereditary angioedema. And C1 esterase can be normal or low, but C4 level will always be low. The differential diagnosis of angioedema sometimes can be very tricky in spite of practicing for so many years. Sometimes this clinical conditions do baffle us as well, especially with this hair dye induced angioedema. The patient presents with this swelling, absolutely mimicking angioedema and absolutely forgetting and denying that they have used hair dye. So it's the repeated questioning that actually will lead to the cause of angioedema. DRESS syndrome is a hypersensitive syndrome where you have facial edema. In addition, there's eosinophilia, there's systemic syndrome, there's extensive skin rash. In dermatomyositis, again, patient can present with facial puffiness. Granulomatous cheilitis is usually patient presents with persistent lip swelling. There can be associated tongue edema as well. Also, superior vena cava syndrome, subcutaneous emphysema, and after facial procedures, patients can develop the subcutaneous edema and present as angioedema. So be careful of those differential diagnoses. So how to manage? So patients with recurrent angioedema, assess the airway stability, consider hereditary angioedema if no response to allergy treatment, and past recurrent abdominal pain and swelling, as I mentioned. So you have to give prompt treatment. Fresh frozen plasma is usually our option, but icatibant is the new drug, or plasma-derived C1 esterase inhibitor can be helpful to manage these lesions. And of course, follow up with allergologist or dermatologist as the need be. So treatment of acute attack, then you can have short-term, you can give short-term prophylaxis, or you can put your patient on long-term prophylaxis, or you can decide on-demand treatment depending on your patient's sign symptoms. So rational decisions in management of hereditary angioedema, should they receive prophylactic treatment or on-demand treatment, will depend on the severity of the attack and the frequency of the attack. And management during surgery or procedures needs special considerations. I will come to that. And management of pregnant and lactating women becomes tricky because you can't use many drugs in them. And children usually responds better to treatment. So probably on-demand treatment is justified for children. So angioedema and surgery, sometimes you might not know during surgery, it could be the first time you come across a patient who can develop sudden swelling of this laryngeal swelling, and they can have features of anaphylaxis. Sometimes it's really difficult to differentiate between anaphylaxis and angioedema. If you are not sure, then do treat as anaphylaxis. If the patient is not responding, then ask for fresh frozen plasma and treat as angioedema. But patients with known angioedema, preoperatively, you can start danazole, fresh frozen plasma, or C1 inhibitor if available. During operation, it's better to avoid instrumentation and general anesthesia if feasible. And even after the procedure, the risk is not over. You have to monitor the airway at least for 24 hours post-operatively. So why it is important? Because it is rare but disabling disease. Identification of the disease is crucial, and not all swellings are angioedema, as I mentioned from the differential diagnosis, and misdiagnosis can lead to potential serious conditions. And understanding clinical features unique to angioedema will help physicians to target the appropriate treatment. Thank you for your time.
Thank you, Dr. Zoha, for a very lucid presentation of a complex topic. And since I think you have some engagement and you have to leave the program, I would hand over to Dr. Saibal for a quick question answer session with her before she goes.
Yeah, thank you, Dr. Swarnaka. So I must thank Dr. Zoha for this extremely lucid presentation. So is there any question? I don't see any question in the chat box. So, well, so if there is no question, then I think, let me just check.
Just one thing, can you,
Yes.
Sorry, one thing, updosing of Omalimumab by mistake, I said twice daily. It has to be twice a month.
That's monthly, yes. Okay, yeah, this one question, Dr. Zoha, that in the acquired angioedema, yeah, this question is, can thyroid hormone therapy lead to urticaria? And like a patient was prescribed Tylenol for hypothyroidism for 1 week and came with sudden onset urticaria and angioedema and attributing it to thyroxine. So the question is being asked by Sentami Selvi Ramalingam. Yes.
Not that I have come across, but if the patient is having thyroid antibody, that can have association with urticaria. But as such, thyroid therapy, I don't see pathologically how it can cause it.
Okay, thank you. I think that was quite clear. And now, okay. So, ma'am, I would like to ask that means those who have this C1 esterase inhibitor normal, that is having an hereditary angioedema, and if it's induced by the ACE inhibitors, so do they need to avoid the ACE inhibitor lifelong, or means it goes away after some time, or it's a disease which stays on for life?
Once, I would say if the patient has developed angioedema with ACE inhibitor, it's always prudent to avoid it, and also the ARBs, receptor blockers, should be avoided as well. Because why make the, and another thing is that ACE inhibitor can cause this angioedema even after 3, 4, 5 years of therapy. Previously, we used to think that it has to be 2, 3 months, but now it has been shown that it can go on for that, can manifest even after that long. So it's better to avoid.
Okay, thank you. So next question is by Dr. Anokar. In C1 esterase study, if C1 inhibitor function is normal, is there need to check the C1 inhibitor antigen as well?
Antigen as well, definitely. It's not that we do it routinely, but theoretically yes, but routinely I don't think we do it. Because if there is, there can be antibody formation, so routinely we don't do, but theoretically yes.
So another question by Dr. Anokar again. omalizumab therapy related to increased IgE level. Any cutoff to consider it? Recommendation if IgE lower between 145 to 160.
Honestly, it's not that if the Ig is low, we know the patient will respond less with omalizumab. That we know. So higher Ig responds better. But if the patient is not responding, you can always upscale the dose and give it a go and see whether the patient responds.
Ma'am, how many days we have to give this omalizumab once we start? Because in asthma we see for 6 months and then we see the
6 months. For us also 6 months. We copied you.
Yeah. So I know about asthma, but I don't know about CSU because of course that is one of the indication which has come up in omalizumab.
Yes. And in urticaria treatment, while we are embarking on omalizumab, there is no need to do a IgE level as we do in asthma. So this is independent of having IgE level.
Definitely, they can have anaphylactic reaction. Yes.
Okay, so there's no more question. So thank you, Dr. Zoha. Thank you again. So I think we can move to the next talk. Thank you. So the next talk is by Dr. Narmada Ashok on insect venom allergy. So Dr. Narmada has already been in, she has been already, I think there's another question which has come up. I think we can take it later. Okay, I think we can take it in the end. And that's the recommendation for omalizumab in urticaria with peripheral edema, family histoatopy, if IgE is between 145 to 158. I think we can have this and end it. So recommendation for omalizumab in urticaria with peripheral edema, family history of atopy, IgE is between 145 to 158. So so I think the doctor wants to know that whether there is urticaria with peripheral edema. So peripheral edema with the family history of atopy. So is there any significance of the peripheral edema? I don't understand. Maybe you might referring to an angioedema. So ma'am, would you like to say something in this?
Well, Dr. Zoha has left, so I think
okay. So
do this thing in the.
I think then we can do it later. Yes. Yeah. So now I would really invite Dr. Narmada Ashok. Dr. Narmada Ashok has already been introduced by Dr. Swarnakar. So we go directly to her lecture on insect venom allergy. Yes, Dr. Ashok, please.
Hi, greetings to you all. I'm Dr. Narmada, and we are going to talk about a very interesting topic of venom stings. The venom stings, the outline of the topic would be the need, the taxonomy of the insect orders. What are the medically relevant insects which we should know, the aphids, vespids, and formicides. About a brief about the venoms, how do we approach to managing the venom stings, and a note about immunotherapy, and final conclusion. So the venom stings, do you really need the topic? That is on the minds of everybody, because most of the insect stings are a very common reactions, and they don't even get reported. There are actually lots of myths surrounding the bites, and most primary care physicians are usually unaware of the significance of the bite. We usually say that it will not do anything, or we think it will be just a mild allergic reaction. Sometimes advices from the public will be ranging from the next one could kill you, or you will outgrow the bites, and they run to the hospital for a very even small bites, but the serious reactions, they don't document it, and the less severe, they do not come to the hospital. The home remedies are also very rampant, and they may prevent analyzing the severity and management of the bites. The literatures in India were scant, but now it is coming up in India. When you think about the epidemiology of insect stings in the world, which gives us a knowledge about the magnitude of the problem, the insect stings can produce both allergic reaction, which can lead up to anaphylaxis, and can also cause inhalant allergy. The commonest type of allergic reaction are usually caused by yellow jacket and honeybee stings in Central and Western Europe, and the paper wasp sting reactions are most common in Southern Europe. Among them, if you see, for globally, about 5 to 7.5% of the total population have suffered some hypersensitivity reaction, and generally about 56.5 to the tune of 94.5% of the general adult population have had at least one Hymenoptera sting. But among them, the sensitization has ranged from 9.3 to 28.7%. The systemic reactions are more common in adults, like to about 3%. That is, among those who have had a sting, among 3% have reported a systemic reaction, whereas the children have a very less severe reaction, and only 1% have reported a systemic reaction. Now, what about India? Do we have any idea about the insect venom hypersensitization here? Yes, we do have in a study done by Arghya Laha and Tanya Sarkar from, they have found out that the evaluation was done among 450 patients, and they used skin prick test to find out the sensitivity, and they found out that the commonest is black ant, which is about 87.62%, fire ant about 84.59%, and honeybee 67.02%, and common wasp about 30.27%. So this was reported by the group from Calcutta. Now, coming to the report from Himra et al., he has reported maximum instance of wasp and bee stings among the patients presenting with severe allergic reaction in Tanda district. And Vikrant et al. Has also reported multiple wasp stings as a predominant reason for acute kidney injury, which had a mortality rate of about 36.1%. And this, interestingly, was higher compared to that of the snake bite, which was only 9.2%. So overall, we have one literature showing that is definitely an indication, there is a sensitization there. And another place that we have seen that the wasp and bee can produce a huge amount of, can produce severe systemic reaction. So definitely this topic warrants the attention of all of us. Now, coming to the animal kingdom, what are the group order which we are really interested here? If you see, Hymenoptera is the order which we are interested, and among Hymenoptera, though there are many families, we are particularly concentrating on the Apidae family and the Vespidae family and the Polystins. So this is the subfamilies we are really interested. In the genus, it is Apis and Bombus, predominantly the bee variety. The wasp variety belongs to the wasp, Vespa groups and the Vespula groups, and then the Polystis also, that the paper wasp comes to the Polystis group. And this is the genes we are interested. Why should we know about the genus and species? Because there is a significant amount of venom cross-reactivity in between the genes. So the Apis and the Bombus will have a significant cross-reactivity, and however, they have limited cross-reactivity in between the species. So we'll have to know about the different genus and species in order to know how do we manage the patients who have insect venom hypersensitivity and anaphylactic reaction. So this is what I said. The Vespoidae, there is one under the Scolioidae, which is here, which is the Formicidae, which is the imported fire ants. So we have the Apidae family, Vespidae family, Formicides, which we have to be worried about. These are the three medically important genus we are worried about, and we are going to discuss in this topic. So when we look at the characteristics of the Hymenoptera stings, they are present in the environment for a larger part of the year. Whereas in Western countries, they may be present in certain season. But here, because we have the environment which is very different, and most often it is very sunny in most of the places, for the larger part of the year, the Hymenoptera are going to be present. However, the stinging incidence appears a little higher during the late summer, and probably it is because of more holidaying during that time, and it reaches a peak in August when the rain starts exactly. So the various environmental factors seems to influence, like that of the temperature of the place, the humidity of the place, the rainfall, as well as the wing speed. Generally, they are not attracted to the humans, and only when we go and provoke their environment, they come and sting at us. But some species are very aggressive. Like a single stinging event can occur when the hungry wasp is attracted towards the food, whereas multiple stinging events in mass can occur when you go to their environment and when we intrude. The wasps and bees are capable of attacking in multiple stinging events. The problem with the single stinging events is they can lead on to a severe anaphylactic reaction. Whereas when you look at the multiple stinging events, we have to think about several non-IgE mediated also, which we will discuss, and their problems are entirely a different segment. So we'll come first to the Apidae family. As we said, it is predominantly the bees variety, and there are three types in that: the bumblebees, the honeybees, and the carpenter bees. And the characteristics of the bee stings in India, luckily we don't have the terrible African honeybee, which is a sort of a killer bee, and it was actually a cross between the species, and it has been spread from, now it is spread from the Africa, and it has gone on to the Europe, and it is spreading because of the change in the environment of those countries, and also due to the global warming. When you take up India, from the time immemorial, we have cultured honeybees, and we are known for our honeys, very tasting honeys. And these honeys they are cultured from predominantly 6 species like Apis dorsata, the rock bees, the Himalayan species Apis laboriosa, the Indian hive bee, the dwarf bee, which is predominantly found in our areas, the European or the Italian bee, and then we have the Pteranodonala, which is a stingless bee that doesn't have any stings. So this is one of these are not very big, they are not like a killer bees, and not very venomous. Unless until we go and intrude them, their intrusion into us is very less, and they're not very aggressive. And one of the very unique concept is this is the bee sting. If you look at the stinger, it is attached to that of there is a bulb here and a retractor muscle, and the venom sac is attached here. So whenever the stinger stings, the venom sac it gets cut off from the main part of the body. That is, autotomy happens. So this is very unique in the way they if you look at it, this is the sting apparatus that stings onto the skin, and it is usually the stinger is left behind. The biggest problem is the sting keeps on releasing the venom still we remove the sting apparatus. So this is what we have to know. However, it is so quick that the 90% of the venom is delivered in the first 20 seconds. So whatever we do, we still have like 10%, at least we can prevent the venom from getting into the body, but 90% would have been delivered in the first 20 seconds. So this is one of the things that is unique. Whenever we find the stinger in the sting, we need to be aware that it was a bee sting, and in India, any of these 6 species is usually possible. Whereas the African honeybee is a very aggressive and can lead on to a severe reactions. Now, coming to the other part, which is the bumblebees, Bombus apidae, which is present in India, they are mostly found in gardens, flat, and stone and bricks. They can be at the underground or the ground level. They tend to avoid humans, and the main advantage is the sting lacks the sparks and hence cannot sting repeatedly, and they will just leave it behind, and they are not very aggressive too. And this carpenter bee is present predominantly in dead woods and bamboo. And again, it stings only while provoked. So these 2 bees are very common in picnic areas, and where when there is some construction work done, and where there is a tendency for the children to go and intrude into the area. So when it is in those types, when there is no hive scene, we have to think about this bumblebees and carpenter bees. Whereas when you know that the honeycomb, the nest has been there, and it has been under massive stinging has happened, then it could be the other honeybees here. Now, this Apis mellifera, that is what we have talked about. The path sting is left behind. It is in the hives. It is not aggressive unless you threaten. The domestic bees, as we said, are very docile, but children can easily get provoked because they try to go and meddle into the environment. Now, what are the characteristics of the bee venoms? If you see about 140 to 150 microgram of venom is being delivered in a stinging event. As we said, with the first 20 seconds, 90% of this will be delivered. But the median lethal dose for the human is about 2.8 to 3.5 milligram of venom per kg. Now, why do we need to know about the 140 to how much dose is delivered? Is when we plan our immunotherapy, It is planned based on the amount of the venom that is being delivered in a single stinging event. The bee venom is also unique. It has got a mixture of compounds like protein, peptides, amino acids, and hyaluronidase. And this is also, some of this are shared with the Vespidae group also. And that is a vast like adrenaline, dopamine, and histamine. So each of these chemicals are very important for one sort of a chemical reactions, that they may be either producing a very stinging reaction. The histamine may be responsible for the huge anaphylactic reactions also. They also have the apamin, melatonin, and mast cell degranulating peptide. These are the compounds which are very specific for the bee venoms and not shared with the other Hymenoptera family. The melatonin is a main and the toxic compound, and it causes a minor allergic reaction but very severe pain. And we all know the bee stings are very painful. The phospholipids is one molecule which we all have to concentrate across the species, because this is the most allergenic and has a heavy immunogenic potential, and it is present in the species which we will see. But what is present in the bee is phospholipase as A2, which is about 10 to 12%. They form a complex with the melatonin, and they can produce the bee hemolytic factor, which is one of the main allergenic compounds. The queen bee has got a higher histamine content, probably contributing to the severe reaction. And the bumblebee venom is antigenically and chemically similar. So even a single bite of bumblebee, though it appears when not aggressive, it can produce anaphylactic reaction if you are sensitized to the bee venoms. So these are the compounds, and the main thing is the peptides, proteins, and hyaluronidase are capable of, once it is bitten, it capable of helping to spread the venom very rapidly in the body. So that is one thing these compounds help, and among this, some are antigenic and some are capable of producing reactions locally too. Now, coming to the Vespidae family, they use wood pulp to construct nests that contain one or more layers of comb. The new queen's mate survive, and the new nest is formed in very favorable season. And they have smooth stings, so they can sting repeatedly. They don't autotomize, so they are capable of stinging repeatedly. And some Vespid stings apparatus, some only can autotomize, but majority can sting repeatedly. They prefer to build a nest underground. And the Vespidae family, we have to be worried because they are found in picnic areas and trash containers. And nowadays we have the habit of going to resorts in the holidays, and very commonly that is a Vespidae family is the one that is found in the vegetation, and they are aggressive scavengers. So if you intrude into the area, they are capable of biting it repeatedly. So they are very aggressive. So coming to the Vespids which are present in India, they belong predominantly to the four families: Huminae, Stenogastrinae, Polystinae, and Vespinae. The potter wasp, red paper wasp, the Indian paper wasp, the sting we all would have had at least once, which is very painful. The Indian yellow wasp, the yellow potter wasp, and the tarantula hawk, which is very aggressive one, the giant hornet, and the great branded hornet. These are the certain species that are present in India, and all of us would have encountered at any one point too. And most of them are aggressive, and they tend to bite if you are going to intrude into the area, and it's very painful. The yellow jacket or the Vespula in tree or shrub, and it is generally encountered during yard work, farming, and gardening. That's a lancer-like stinger with small barbs, and we said occasionally only it is left behind. Predominantly the bees only autotomize more. They are mostly found in picnics and in orchards, trash cans, and dumpsters. Now coming to about the hornets, the giant hornet, it's a very large and venomous sac. It is a neurotoxin, so you sort of get one a numbness feeling, but the stings are also, the insect itself is a very aggressive one when the nest is disturbed. The polysters this is found, their nests are very open and the cells are not covered. There is an increased likelihood that in the outdoor events, when they come to the area where the food and drink is served, and only when the nest is threatened, they do dry test. But one of the possibility is these paper wasps easily go into the Coca-Cola drinks or the containers which we drink. And sometimes when the container is open, only a small bit, when they enter and we drink it without noticing it, there is a possibility that they sting directly into the tongue, which can lead on to severe anaphylactic reaction. They are also capable of stinging repeatedly because they do not autotomize. Now coming to the Vespid venom, the characteristic, they are more variable in composition than bee venom. They have powerful allergens. The major three proteins are the antigen 5, phospholipase A and hyaluronidase. This I have already alluded in the previous slide. Here, what is very specific in the VESPID is PLA1B, which is very specific of the VESPID and are highly cross-reactive. The hyaluronidase is also present there, and this can also induce severe fatal anaphylaxis. This is masterporons, like melatonin B. The masterporons are very specific for the VESPIDs, and they're tetra-decapeptides and capable of anaphylactic reaction. Bradykinin, calidin can also occur in humans, and they are all stored in the women. They are the important mediators of inflammatory responses. They are potent pain producers and also capable of increasing the vascular permeability. The last is the formicide. Now, among the three species, apid we have discussed, VESPIDs and the formicides. Because we are worried about the giant red ant. Now, what we do have, the little black ants, which we see here, monomerium. The fire ant which is found here is the Solenopsis, which is capable of producing a severe reaction, allergic reaction. We are having the house ants, the Pharaoh's ant, carpenter ants. So these are the ants that bite but not capable of creating any bigger allergic reaction. But of course, the Solenopsis can cause life-threatening reaction, and it is potentially a very painful one. And usually, if you find that the venoms are is mainly alkaloids, they form a sterile pustule at the sting. This is one of the very key characteristic feature. Like in B, we have the stings. Here we have the sterile pustule, and each can transfer about 100 nanogram of proteins, which is very important for us to know when we are doing the immunotherapy. And they are the major component again here is phospholipase, which is phospholipase A1, and Sol-I2 is a protein present in venom of other species, and they can cross-react 67%. So there is a lot of cross-reactivity among the species. So why the knowledge of all these things is very important, because we have to know what are the indigenous insects and what are the bites which are very common, and how do we plan our further course of therapy and immunotherapy. Now, generally, the venom stings can produce a local reaction. They can produce, the local reactions are either usually small or larger. For the smaller edema, erythema, pruritus, and induration only will happen. This is something like a smaller reaction. But the larger local reactions are such that they usually cross about 2 joints or more than 10 millimeters. So this is a larger one. So now, the systemic reactions are one which we are really worried about, because we do investigate patients who have the systemic reactions. Adults more than 16 with systemic reaction are the persons who are investigated, sensitization is found, and further courses planned. So the systemic reactions are more common, as we already said, it is more common in adults compared to that of the children. And the systemic reactions without any cutaneous symptoms can occur in adults in 15%, whereas cutaneous symptoms and signs will occur in 80% and 95% of children with systemic reaction. So we need to look at for the cutaneous reaction. Now, the systemic reaction, as we said, the cutaneous are pruritus, urticaria, and angioedema. But some people have, without the cutaneous reaction, they will have GI symptoms, cardiovascular, neurological, and respiratory. Cardiovascular, they can produce tachycardia and hypotension. Neurological, lightheadedness, dizziness can occur, and respiratory, rhinitis, and shortness of breath. Now, what we are also worried is a non-IgE mediated reaction, which can occur when there is some massive bites, which can happen with honeybees and wasps. So they can produce necrosis. The renal, they can produce interstitial nephritis and rhabdomyolysis. Hematologically, they can produce hemolysis, cytopenias, and DICs. And neurological, they can cause even Guillain-Barré syndrome that can manifest later, a week later after the insect bites too. And they can produce alveolar hemorrhage and respiratory. The only thing we need to worry about in the non-IgE mediated reaction, whenever there is a massive envenomation that has happened, do not discharge the patient very quickly. We need to wait at least 72 hours for a week and have a high index of suspicion for the non-IgE mediated reaction. So massive envenomation, one problem is the immediate IgE that we get over 24 hours. If we manage, we are okay. But then the non-IgE mediated can go on after 72 hours also. So we have to monitor the patient. So how do we predict the risk of severe systemic reaction? Severity is very difficult to predict on the basis of previous reaction. Just because the previous reaction was having a severe, we cannot say this is going to be severe or that was mild, just had a cutaneous reaction. We cannot say this will not go on for respiratory compromise. As we said, children suffer from more cutaneous reaction compared to that of an adult, whereas adult, because of other comorbid features too, they have a cardiorespiratory compromise. The exposure, the beekeepers, pest controllers, those sort of people who look out for outdoor sort of an occupation and outdoor sort of hobby, they are more prone. And when you have a plasma tryptase is something which we have to always do because it will help us to rule out systemic mastocytosis. Atopy does not predispose to systemic reaction, but if there has been an asthma, then that's a major risk factor for them developing anaphylaxis. And the disease is compromising on cardiac. Many adults would be on cardiac drugs and they are prone for the systemic reaction, which is very severe. So grade 4, generally, this is something which we are already seeing. Grade 1 is just only urticaria, whereas grade 2 goes on to have involved 2, 3 systems also. But grade 4 is when there is a fallen BP, loss of consciousness and incontinence or cyanosis. This is like a life-threatening emergencies. So the management depends on what type of reaction people have. That's a local reaction. It requires only the management is only for the pain relief. But whereas the systemic reaction, when the severity increases, they may need an emergency and aggressive management. And coming to the long-term management, many persons do not require medical attention. But if they have developed a large local reaction or there is a chance of they may have a risk of systemic reaction, we need to investigate them. They need evaluation and treatment, and the detailed health history will help in the diagnosis. So the factors that will help in identification is what we have already discussed: the type of patient's activity, the type of bites that is more common in the area, the type of what kind of insects are usually found. That is why we stressed upon those types which in the previous slide. And visual identification can help in the presence of the stinger. We know it's a honeybee, and if it's going to be a pustule, it is the fire ants. We also have to look into the patient's occupation, the hobbies, and comorbid conditions and concomitant medications. If we are on beta blockers also, we have to need to observe them for a much longer time. This is the history that is going to help us. Do we have any specific investigation? Yes, skin testing is something that is the first line of investigation, and it is a gold standard to confirm the type. We do identify the insect. We will do for all the insects because, as you know, there is a minimal cross reactivity across species, and mostly the venoms are the Apidae, Vespidae, and the formicides. And it is done on the patients more than 16 years of age who have experienced a systemic reaction. Skin testing is not recommended for patients younger than 16 years of age. So we, who are the candidates of venom immunotherapy, is who have experienced a systemic reaction and who can experience, they will have a severe reaction further. So these are the patients who are potential candidates for venom immunotherapy. These are the children, these are the adults whom we need to investigate. The timing of testing, we need to wait for about 4 weeks after the stinging events to allow enough time for the cutaneous mast cell to replenish. And the type of extract used, we studied about a lot of the venom. So venom protein extracts are for the diagnostic testing. But in case of the fire ant, we'll be using the whole body extract. Because that has got sufficient venom. But unfortunately, we are not having any of the extracts here. But definitely, and we know about them. We can procure them from the West. Now that it is easy to procure some, we should definitely try to investigate these cases. And I think when more number of us start doing it, these extracts will become available here too. And the venom skin prick testing is almost similar to that of the other testing we are doing for allergic thing. But the only thing is here, if the tests are negative, the intradermal skin test has to be performed before declaring completely negative. So what we do is we start with the skin prick concentration of 1 to 100 microgram. Start with 1:1,000, 1:1,000 dilution, 10,000, increase it completely in tenfold increments until we reach about 1:50 or 1:1,000 is reached. So till that time we have to increase, and we also have to follow it by, as we said, with the intradermal testing. Why? Because before starting on venom immunotherapy, we have to find out whether there is the sensitization is definitely present. So we concentrate, concentration is increased from 0.001 to 1 microgram per liter. But the pitfalls in skin testing is like you cannot get the positivity when there is predominantly a non-IgE mediated reaction. Now, if you do the serum testing, serum specific IgE can be done for these patients, but the clinical correlation is very less when you're doing little lesser compared to that of the skin testing. So that is why we prefer skin testing more than the serum testing. And both of them, if you're getting the history and the serum testing alone is positive, we still try to establish because they do not correlate in 10% of the patient. Again, one more thing is the level of sensitivity of venom skin testing or serological testing does not accurately predict the risk of subsequent reaction. So, but still, they definitely tells us that sensitization has been present, and when there is a correlation with the history and if there is a risk of future systemic reaction, these are the ideal candidates who will go for immunotherapy. Now, coming to the serum testing, as I said, the clinical correlation is less, but the positive result, the specificity is more higher, and the positive result is when there is the levels you get as 0.35 kilo units per liter, and it's actually used as an adjunct and not as a standalone test. Component resolved diagnostic testing has been increasingly used, like they show dual sensitivity, and you want to be very clearly what is the insect that is sensitized to, then we can do component resolved. CRD is generally used when there is a cross-reactive venom and you want to know the exact sensitization. Serum tryptase level we have already spoke about. This is for ruling out systemic mastocytosis, and serum total IgE generally are not very useful. Venom immunotherapy, I'm very sure immunotherapy will be discussed in the lectures. But here, when the immunotherapy in venom is very significant because the efficacy is almost to the tune of about 95 to 97%, and it is the only specific treatment currently for reducing and preventing systemic reaction. It is used, as I said, with in patients with demonstrable specific IgE with a history of systemic reaction and anaphylaxis, and there is a heavy risk of future reaction. The goal is to reduce a life-threatening reaction, and secondary benefit is to alleviate anxiety related to the same. Because then they would have undergone a lifestyle change because of this, and they're very much afraid to go about, and their entire career is dependent on that. Then those patients, we would definitely offer the immunotherapy. May also be considered in those mild reactions with risk factors such as race, that is, they have the plasma mastocytosis, increased likelihood of future stings. They have a remoteness from emergency medical help, and as we discussed about the effect on quality of life. So these are the conditions we will have a less threshold for starting immunotherapy. Definitely, it is not indicated in local reactions and not for patients 16 years of age or under. The indications for immunotherapy with clinical reaction, which is given by Indian guidelines, severe systemic reaction with positive specific IgE. You don't have don't have IgE, you will not start. So you need to have a good history, severe systemic reaction, and demonstrate the positive specific IgE. So, and if you will go for the mild reactions for immunotherapy when there is an evidence of psychological affection or the lifestyle is predominantly affected due to the same. So the protocols, we will involve a series of subcutaneous injections, again commencing at a low dose, and we will gradually escalate. And this maintenance dose of 100 microgram is maintained looking at the concentration of the toxin that is released. We discussed that it was in the bee venom somewhere about 140 to 150 micrograms. So that is why we are going up to the this maintenance dose. And it is calculated for about 3 to 5 years. And sometimes we may need to give lifelong when there is systemic mastocytosis. There are 3 types of protocol which we will discuss in the next slide, and systemic reactions are more common with honeybee venom than with westpit venom. So this is what the conventional therapy is about 12 weeks, whereas the cluster therapy, the cluster we do it in 7 weeks duration. The rush and ultra rush is between 3 to 4 days and 1 to 2 days. This is really when they want to go back to their work or when they are planning a holiday and they are in a rush to go, then that is when rush and ultra rush is taken place. But this is an extremely rare circumstances and when there is a clinical indication and we don't offer it as a OP therapy, this has to be given only in the IP, and the systemic reactions may be very intolerable. This is only when they have to be protected immediately, and we need an intensive care space when we are giving the ultra-rush therapy. Conventional, we take about 3 months. It's mostly an outpatient management. The systemic reactions are less, and when there is we give it when they have time to come to us and get the reaction, and they do not get themselves exposed during the scene. The time constraints are the longer duration only, and the prolonged clinic requirement will not be just that they have to stay there till the reaction is there. Whereas in ultra rush, as the timing reduces, it is more about the intensive management in that clinic when we are going to give the immunotherapy. So the contraindications are active immunological diseases, active cancer, when the asthma is uncontrolled. See, asthma is also capable of producing the systemic reaction. And again, when we have uncontrolled asthma, these are the same patients who we cannot do for venom immunotherapy. So we need to balance. Chronic heart or lung disease, pregnancy, we do not initiate, but we can maintain. And those who are on immunosuppressive and cytotoxic drug, we don't give them. As we said, that is it's very extremely efficacious. Maximum efficacy is highest when we use mixed despite venom, and it is 98% effective at a maintenance dose of 300 microgram and about 95% effective at 100 microgram. But most of them will do good at 100 microgram itself. The immunotherapy failure, when we say that when the insect is the same and they have developed another reaction, then we sort of try to increase the dosage to give them maximum protection. The decision to stop immunotherapy is very individualized. You have to discuss with the patient. We'll have to see what is their time commitment, how do they work, and what is their hobbies, what are the factors that is disturbing them. All this, and if there is a systemic mastocytosis, there is no other way than to continue for life. So we have to discuss. It can range from 3 years to indefinite and depends on the individual patients. The risk of recurrence after stopping immunotherapy is more with those who have honeybee allergy, who have had a very systemic reaction, who have received treatment for less than 5 years, and those who had a near fatal reaction before treatment. So all this we should consider before discussing with them. So the take-home messages are anaphylaxis to insect skin can occur in 3% of the adults. And India also, there is a chance we do have massive envenomation as well as individual stings that has produced anaphylaxis. Sensitization is there, which has been demonstrated in the studies. So cutaneous systemic reactions are more common in children, and hypotensive shock is more common in that of an adult. So it varies up to 25 to 70% in adults, depending on the previous reaction. Venom skin testing is the most accurate for diagnosis. However, the degree of sensitivity will not predict, but if it is positive, there is a positive history, and there is a likely reaction that they will develop future reaction. We need to talk to them about epinephrine, which is very important. We need to offer them immunotherapy, which is about 98% effective in preventing anaphylaxis. Better tests are needed for markers of susceptibility. Of course, CRD and all is coming up in India. And one more thing is we need venom immunotherapy. We need the allergens here. We also need to think about the starting of immunotherapy in our patients. I thank the organizers for giving me this excellent opportunity to interact with you all, and I'm available here to answer your questions. Thank you.
I would really thank you for this comprehensive lecture in which you covered all the aspects of the insect venom allergy, the Hymenoptera order, and all the things has been clearly, you have covered everything. So we can have the questions in the end and during a panel discussion session. So I would like to now move on to our next topic. So our next talk is on the air pollution and allergy by Dr. Rajadhar. Dr. Rajadhar is well known to all. He is an excellent orator, the director of the pulmonology in CMRI hospital. So I would ask the Sanofi team to display his recorded lecture.
Hello friends, I welcome you to the third chapter of the Allergy and Immunotherapy module that's been designed so very nicely by Dr. Shoibal Moitro and Dr. DJ Christopher. My ambit today is to speak about air pollution and allergic rhinitis. I will do this in the next 15 odd minutes, talking to you a little bit about air pollution. I will speak about allergic rhinitis, and then I'll marry the two together, tell you how air pollution as a trigger worsens allergic rhinitis, and what are the therapy modalities which might be available in combating this particular menace specifically. So I have a definition here for air pollution. However, air pollution is more a description rather than a definition. And you all know that substances which are emitted by processes and sources such as fuel combustion, power generation, industrial facilities, agricultural waste sites, etc. So these processes result in the release of particles which are emitted into the ambient air, and they can be in the form of solid particulate matter, could be liquids, or could be gaseous emissions. Why is this important? This is important because this results in new symptoms in people who do not have any pre-existent allergic disease or airways disease, or it might result in symptom exacerbation in people with pre-existing allergic disease. The components of air pollution which result in this exacerbation include gaseous compounds like nitrogen dioxide, nitric oxide, sulfur dioxide, carbon monoxide, carbon dioxide, etc. Solid particulate matter, which are airborne PM as we call them, and traffic diesel exhaust particles. The most offensive of all of these is probably the diesel exhaust particles. These are solid agglomerations of carbonaceous material, and we'll come back to this in greater detail as we go along, but they also have volatile organic and sulfurous compounds which are emitted by diesel engine fuel, and they come in various particle sizes. And again, we'll discuss this in greater detail as we go along. So diesel exhaust particles, which we'll term as DEP from now on for ease of pronunciation. So DEP particles have a trimodal distribution. You can have PM10 particles, which are of a diameter of less than 10 millimeters. You can have fine particles, which are PM2.5, which are less than 2.5. And then you have ultrafine particles, which would actually get absorbed and go into the bloodstream, which are of a diameter of less than 1. The particle size governs which bit of the airway it will implicate, or in case when the PM is less than 1, it would even go into the bloodstream and cause systemic manifestations. You can see that we have said that PM10 can reach the lower respiratory tract, PM2.5 can penetrate the lung, and PM1 can penetrate into the alveoli and reach the bloodstream. And that's something I want you guys to remember. So that's about air pollution. A little bit about something simpler, allergic rhinitis. So allergic rhinitis is a multifactorial disease. And that's why you have physicians from various specialties discussing about allergic rhinitis. There's some evidence which supports correlation between air pollution and allergic rhinitis. There's this recent Lancet commission which suggests that pollution is the largest environmental cause of disease and death. I'll say that again because it has serious implications for the developing world, countries like the Indian subcontinent, Africa, and so on. So largest environmental cause of death and disease globally. And a large majority of this pollution is the result of burning of combustible fuel and biomass, which accounts for 85% of airborne particulate pollution. So that's the greatest source. It is burning of combustible fuel. Diesel exhaust has been estimated to account for 80% of human exposure to particulate matter. And the level of PM is unfortunately the highest in the largest of cities. So greater the size of the metro, the greater the chance that the PM 2.5 is highest, and hence the airborne particulate matter density is the highest. There have been epidemiological studies which have correlated air pollution to an increase in allergic and respiratory symptoms. And individuals with AR who have inflammation of the nose, who have nasal hyperresponsiveness to various stimuli, makes them more responsive to airborne stimuli and hence exacerbates symptoms of allergic rhinitis. All of us know about the declining air quality in India. No wonder, and shame on us, that we have 9 of the 10 world's most polluted cities. If you look at 15, it's 13 out of 15. The ill effects, as you know, are manifold. Declining air quality has a disastrous effect on human health. And it's not just the upper airway, not just the allergic rhinitis, not just the airways disease, not just the asthma or the COPD, but the effects are multifactorial. They affect every single system in the body. The worst impact, however, is in people who have pre-existing respiratory disease. And here I am including allergic rhinitis within the ambit of respiratory disease. The worst by far is Delhi. Delhi has been recording an annual average PM 2.5 concentration, which is more than 10. Think about it. The AQI in Delhi is often above 400, whereas the recommended levels are below 50. That's how polluted, how poisonous the air in the metro cities in India are, what we breathe in on a day-to-day basis. What's the global burden of disease study say about air pollution in India? So air pollution levels, like we have said in India, are the worst globally. The annual population-weighted mean exposure to ambient particulate matter was about 90 in 2017. And lo and behold, more than 3/4 of the population, 76.8% of the population, is exposed to annual population-weighted mean PM 2.5 of more than 40, which is what is the recommended level by the National Ambient Air Quality Standards of India. So far higher than what is recommended even by Indian standards. Let's now bring COVID in. No discussion even today can be complete without discussing the impact of COVID. So with all the very bad implications that COVID has had, we've had a horrid time, a horrifying time in the last 2 years. One of the things that's happened, which was good during COVID times, was the result of lockdown. The fact that the diesel exhaust particles that we spoke about came down significantly. Vehicular traffic stopped during the lockdown period, and the air pollution levels came down to a level never seen in India in the last 25 years. So there's one good thing that came out of this. It didn't come out of COVID. It came out more as a result from lockdown, but the PM 2.5 and the PM 10 levels came down significantly. However, we are going through a phase, or we've gone through a phase now when lockdown has gradually been lifted. And there's this study which comes from Shukla et al., which looks at how the PM 2.5 and the PM 10 levels have gone up again in the unlocking phase. So 3 different sites that is being looked at. They are all sites in North India. And you can see that it shows that the PM 2.5 has gone up by about 500 times in site 1, about 280 times in site 2, and again about 200 times in site 3 during unlock 8 phase versus the concentrations in the lockdown period. The same stands true, or similar numbers are true for the PM 10 levels. So our learnings from COVID times in the way of lockdown and reduction of vehicular exhaust has not really translated into anything positive during the post-lockdown, the unlock phase. So why are we talking about this? Why is it so important? It's important because air pollution has a significant impact on health generally, but specifically on respiratory health. We know that during the winter season, when the air quality index is at its lowest, at its highest, the AQI at its highest, the air quality is at its lowest. During these times, hospital admissions from conditions like asthma, COPD, even lung cancer are at its greatest. The adverse effects on the respiratory system of air pollution is the greatest between November and February, especially in cities like Kolkata, Delhi, Chennai, Mumbai, and so on. Targeting air quality standards laid down by WHO can reduce morbidity and mortality significantly. So morbidity and mortality from air pollution, but because this impact is so large, if you could reduce air pollution significantly, if you could comply by WHO standards, it would actually come down. Generally, mortality would reduce and life expectancy would improve significantly. What are the various impacts? And I have put these in boxes for you here. So you can see we've talked about mortality generally. The incidence of lung cancer is the greatest in cities in India where air pollution is the greatest. Frequency of symptomatic attacks of airways disease, especially of asthma, becomes greater. More number of lower respiratory tract infections. Heart disease is greater in areas with air pollution. The prevalence of wheezy kids, children with wheezing generally is greater. Chest tightness is greater. People producing cough and phlegm, often like smokers do. And these are people who've never smoked maybe, but live in the polluted cities we spoke about. So production of cough and phlegm requiring medical attention goes up significantly, and acute respiratory infections go up. Eye, nose, and throat irritation may be so significant that they might interfere day-to-day activity. So that's the allergic rhinitis component that we spoke about just now. The Asia Pacific Association of Allergy, Asthma, and Clinical Immunology, the Apache group, in 2020 spoke about climate change, air pollution, biodiversity, and impact of allergic disease. And you can see underlined there are topics that we have discussed already. And I won't repeat all of them, but you can see the increased prevalence of asthma and allergy, increased urbanization resulting in air pollution, climatic change. There should be active government's policies to fight air pollution is something that they have said, and better control of asthma and rhinitis would achieve huge health benefits. And that's the box that we are concentrating on today. Better control of asthma and rhinitis will achieve huge health benefits. This slide looks at the impact of allergic rhinitis specifically in allergic rhinitis patients. You can see on that slide two studies which are quoted. The first is from Dr. Ellis's group, which is a phase 3 single center sequential parallel group double-blind randomized controlled trial with 250 odd patients with allergic rhinitis. These people were subjected to ragweed pollen and diesel exhaust under controlled environment. So this was controlled environmental exposure to these agents. And once exposed, they were given fexofenadine hydrochloride and 180 milligram. So 2 points that came out: exposure to these agents, be it DEP or ragweed pollen, caused significant increase in symptoms of allergic rhinitis in these individuals. Second, use of fexofenadine significantly decreased pollution-exacerbated allergic rhinitis symptoms. The TNSS there, and we'll speak about this again later on, are the nasal symptoms, the total nasal symptom score, which is a good measure of the severity of allergic rhinitis. So TNSS score, or the total nasal symptom score, is something that we will allude to again on multiple occasions as we go along. The other study, the Hauser study, which dates back to about 20 years, looked at something similar. Small number of patients, but a randomized crossover exposure study, which has probably the greatest strength of evidence. 5 adults with allergic rhinitis and 3 adults who were non-atopic. They were subjected to residual fly ash particulate matter, but also to other triggers like ragweed pollen, birch pollen, and oak pollen. If you look at the nasal lavage of these individuals, there was a very large increase in the leukocytes and neutrophils in the nasal lavage. This was more so in people who were atopic. So the 5 adults who had allergic rhinitis, the lavage showed more of leukocytes and neutrophils. However, the effect in non-atopic individuals was far lower. However, interestingly, the interleukins, so the active phase agents like IL-3, TNF-alpha, and the total IgE were not significantly enhanced in those individuals. So maybe the great impact is on the upper airway, which is why the nasal symptoms get worse. The nasal fluid wash shows more of leukocytes and neutrophils, but it doesn't translate into a greater inflammatory reaction with rise in interleukins and TNF. Let's quickly look at the WHO air quality guidelines. I'll be brief with this. However, for all of you who are interested, and you guys should all be interested in this, do have a look in greater detail, because it tells you exactly what are the points that need to be focused when we talk about air quality. The reason World Health Organization came up with this guidance is to protect population from the adverse effects of air pollution, and the global reference for assessing whether and how much exposure of a population results in the various levels of air pollutants causing health concerns is also something that this document looks into. So you can see that there are 3 different levels that we are looking at here. We are looking at the AQG, which is the short-term goals that need to be achieved in people as far as air pollutants are concerned. And then you have the annual and the 24-hour levels. So the AQG level is ultimately what you're finally aiming for, whereas the annual and the 24-hour levels are what you're aiming at on a shorter term level. And you can see that we've got interim targets, which are gradually going down. And the aim is to attain air quality numbers, which are targets for World Health Organization as you go along. And these are for PM 2.5, PM 10, ozone, nitric oxide. So various gaseous compounds are measured, and the aims vary depending on whether it's annual, 24-hour, or the AQG level that you're aiming for finally. The other good practice statement is about black carbon or elemental carbon emission. The World Health Organization recommends that systematic measurements of these should be done. They should not reduce existing monitoring of pollutants that are there in the guidelines already, but these are add-ons. We should have production of emission inventories, and the measures to reduce the black carbon and the elemental carbon should be within jurisdiction, and appropriate standards should be developed nationally. The other one that we have spoken about already is ultrafine particles. So when we talk about ultrafine particles, we are talking about sizes of less than 10 nanometers. And the finer it is, the greater the chances that it deposits deep into the lung and then goes into the bloodstream. Again, the World Health Organization recommends that you monitor air quality, you look for ultrafine particles that are existing, and you add this to the other existing measurements that we have spoken about. It's important to utilize science and technology, they have said, to advance approaches to the assessment of exposure to ultrafine particles and for use of these in epidemiological studies for management. The last point I mentioned is about sand and dust storms. So sand and dust storms is an emerging problem. It's an emerging problem everywhere, but especially in countries like the US, Africa, etc., where sand and dust storms are larger in number. There are again various strategies laid out in this document which look at reduction. This is a problem in India, but less so. And hence I leave it to your good devices to read through this WHO Global Air Quality Guidance to gain more knowledge on this. I finish off in the last 2 or 3 minutes discussing management of pollution-associated respiratory complications. What are the approaches that we need to adopt? So to reduce the adverse effect of air pollution, you need to regulate daily activity according to AQI. We spoke about this already. So on a day in a city like Delhi, when the AQI is above 200, and it often is, or in Kolkata, when the AQI is above that number, you need to limit going to school. People who need to walk long distances, people who work on the roadsides, there should be some way to protect these individuals when the AQI goes up. So that's about outdoor air pollution. Similarly, there should be measures of indoor air pollution. Particle filtration can be effective in reducing PM quantity, particularly in homes. Plants, potted plants are important. If you have air filters, there's some amount of evidence about air filters reducing the amount of particulate matter within homes. Make sure that dietary nutrients have been looked at. Use of masks have become much more acceptable now with the COVID-19 pandemic, and maybe this should continue, especially where there's a worry about ambient air pollutants being at a high level. And it's never not to say about smoking cessation. That's something that we need to mention every time we add to the injury. Smoking cessation is something that you can do. For air pollution reduction, you have a contribution for sure, but it also depends on a lot of factors, political factors, governmental factors, etc. But smoking cessation is something you can do yourself to reduce lung harm. The EPA recommends air quality index value action to protect health from particle pollution. And you can see the values of AQI go from good to very unhealthy. And you can see above 200, which is the number I've kept quoting as being very, very unhealthy. So that's what we are looking at. And there's a range, and one needs to protect your health depending on the AQI value in the area where you live in. These are the international expert consensus group, which has looked at recommendations for patients. And this we have spoken about: avoid tobacco, eliminate sources of indoor molds, and then use of medications like second generation non-sedating antihistaminics. We spoke about fexofenadine. There's also intranasal corticosteroids. Nasal lavage is something we are increasingly asking patients to do. Use of anticholinergics when clear watery rhinorrhea, a lot of dripping of the nose is a problem. Use of anticholinergics is useful, and avoid exposure to aeroallergens and air pollution. I finish off showing you a bit more of evidence. This was a great study looking at the effect of fexofenadine on allergic rhinitis aggravated by air pollution. And it again looks at the nasal symptom score, the TNSS, and they found uniformly that the TNSS was lower, so better among fexofenadine treated subjects as compared to placebo treated subjects. So broadly speaking, anti-allergics help in allergic rhinitis, which is triggered by air pollution. And there's good amount of data, especially about fexofenadine. This is the effect of fexofenadine on air pollution, the same study. And it again shows that the total nasal symptom score at all time points was consistently lower in the fexofenadine treated group versus the placebo treated group. So I'll finish off there. I've run out of time. So I'll finish off and say that respiratory tract infections, both upper and lower, are very important when air pollution levels remain high. And we are talking about exacerbations of asthma, COPD, and if allergic rhinitis is poorly controlled, the chances that you get an asthma attack is so much greater. In the long term, diseases like lung cancer are a huge risk. And we've seen this, especially in cities, metros, where air pollution is an ongoing problem and the AQI levels are above a certain value. The PM 2.5 annual AQG levels has been lowered from 10 to 5, and the fact, thankfully, that non-sedating antihistaminics like fexofenadine or intranasal corticosteroids are useful in the management of allergic rhinitis aggravated by air pollution. I hope you found some of that useful. I would await questions, and I wish you happy learning from the allergy immunotherapy course, which will go on to the finish. And we look forward to your questions, your suggestions, so that we can make things better as we go along for the ICS modules. Thank you very much.
Been benefited by his talk, so where he mentioned in detail about the impact of the air pollution on the allergic rhinitis. So we will have the questions in the end, in the panel discussion. So now we quickly move forward. Our next talk is on the use of biologicals, the treatment of the asthma and allergy, which will be taken by Dr. Deepak Talwar. Deepak Talwar, he is one of the most accomplished pulmonologists in the country, being a senior consultant and chairman of the Metro Respiratory Center for Metro Center for Respiratory Diseases, Noida. So it's over to you, Dr. Talwar. So let's start with your talk.
Thank you, Saibal. I think I have about 17 or 18 minutes because the program finishes at 9:30.
It finishes at 9:30. Yes.
Okay. I'll try to cover as much as possible in this 15 minutes. I've been given the task of talking about choosing biologics in allergic asthma. So the most important reason is, why do we choose biologics in allergic asthma? Because if we look at the GINA step 5, once you have exhausted all your inhaled therapy, which is ICS, LABA and LAMA, you are left with an option to go to biologics, and it is written here clearly. You can see whether you choose track 1 or track 2, that refer the patient for phenotypic assessment and choose either anti-IgE or anti-IL-5 or -R or an anti-IL-4-R. So these are the options which are available, except if you look at the other options in which you have a low dose maintenance oral corticosteroid or azithromycin. So ultimately what you are left with is that preferred choice after the patients are on triple therapy is the biologics. The reason being, the oral corticosteroids, even in low dose maintenance, can lead to a significant risk of development of diabetes, osteoporosis, dyspeptic deciduous, as well as cataracts in these patients. To shun away the oral corticosteroids, you need an alternative, and alternative is here biologicals. So we have 3 group of biologicals as an option: anti-IgE omalizumab, anti-IL-5 anti-IL-5R blockers, which are mepolizumab and benralizumab in India available. And the third group is the one which targets the anti-IL-4, also /13, because the anti-IL-4 receptor is shared alpha subunit with the with the IL-13. And hence it is a blocker which basically blocks 2 cytokines, IL-4 and 13, that is dupilumab. So to choose one of these 3, you need to have the important identifications of touch points in management of this severe asthma patients, which require precision medicine. So you start with identifying the treatable targets for these patients, that do we have those targets or those traits in your patient which can be treated with the help of biologics. If they have, you start climbing the ladder and look for the next point, which is to phenotype this, that is it a type 2 asthma for which biologicals are available, and then endotype them, whether you need to use an anti-IgE drug or the other drugs which are anti-IL-5 or anti-IL-4. And then we'll look for the eligibility criteria, whether this patient fits into the criteria of which biologicals which are available in our country. And for that, because most of them are fitting into both of them, we really need to match the predictors of response to choose an appropriate biologicals. And once we do that, it is very important in the last to match with the comorbidities. And that is for the severe asthma who have an overlap group to match with their comorbidities. And all these 6 points are the touch points in the life of the patient. So taking a decision requires a shared decision, which needs to be taken with the patient, the patient's caregivers, as well as yourself, where you decide that what is perhaps the best for the patient. So first touch point is, what are those reasons for which you want to use biologicals? And are these reasons good enough to use biologicals? Because in clinical research, the biologicals have been shown to be effective in controlling them. So as per the data, the biologicals have been shown to reduce exacerbations, reduce hospitalizations, eliminate OCS use, and improve the quality of life. So if these are the entire gamut of uncontrolled asthma features in an individual patient, you can choose the biologic as your target is likely to be achieved by using the biologicals. How much is this target's predefined cutoffs? That needs to be decided between the patient and you as a decision which is primarily based on the research. So if the patient had exacerbations 4 or 5 times in the last year, you know that the biologicals can reduce it from 40 to about 80% reduction. So you can expect to tell him that you will have perhaps 1 to 2 exacerbations if these biologicals are successful. Similarly, the second point in the mind of the patients is the oral corticosteroid use. So if they are on 15 or 10 milligram of oral corticosteroid, we know that some of the biologicals may be able to reduce it to 100% zero, or there may be about 50 to 70% reduction depending upon the biologic we choose, the biologic which matches the patient's expectations, and those expectations with which we are going to go, we are going to have a predefined cutoff. Most of the times when we talk about oral corticosteroid use, patient's perspective or patient's desire is to come to zero, and that's what we look at the period of 4 months, 6 months, or 1 year, and that predefined cutoff is discussed with the patient. Improving quality of life, it is very difficult to put a number to that. So mostly it is the patient who puts up in a way that he's about 80% better, or it's a global assessment by the patient and the physician together. Lung function improvement is in fact least in the minds of the patient, but most in the mind of the doctors and the treating physician. And you need to see that how much lung functions can be improved. 200 ml, 300 ml improvement in FEV1, or sometimes even up to much more than that can be achieved in a patient. But you will put a minimum number to look forward to once you start the patient on biologics and monitor them for the improvement. Once we have done all this, we are very sure that we need to use biologicals in right candidates. And the right candidate is a patient who has a severe asthma, which is type 2 type. What is type 2 severe asthma? Type 2 severe asthma is the one which is characterized by type 2 inflammation. And type 2 inflammation is characterized by early childhood onset or early adult onset asthma, with a lot of allergic comorbidities which are classically seen in type 2 inflammation, like atopic dermatitis, allergic rhinitis, nasal polyposis, allergic bronchopulmonary aspergillosis, eosinophilic granulomatous angioitis. And very importantly, this type of inflammation is exclusively sensitive to oral corticosteroids. So they become better when they are given oral corticosteroids. Only when they are not, when they are tapered off the steroids, their symptoms worsen, or the symptoms are inadequately controlled on oral steroids, because we want to keep the dose of oral steroids at the lowest possible level, which is considered as about 10 milligrams per day. Along with clinical features, we also look at some biomarkers in these patients to identify type 2 inflammation. That is the blood eosinophil more than usually 300, exhaled breath matter oxide more than 20 parts per billion, or sputum eosinophils more than or equal to 2% in the sputum. So if the patients meet this criteria of type 2 inflammation, we call them as type 2 severe asthma, and these are the candidates for the biologicals to be used. After this, we come to the third touch point, that the patient has type 2 severe asthma. Is it IgE mediated, which is atopic asthma, or it is eosinophil mediated, which is called eosinophilic asthma? So IgE mediated is generally the asthma which sets in at a younger age group, usually in the childhood, while eosinophilic asthma is the one which comes later in age, and is perhaps around the middle age where you get it. The IgE-mediated asthma is typically associated with allergen exposure and has a skin prick test or specific IgE positive to perennial allergens, to which a direct relationship with the allergen exposure can be established. While no such allergen exposure history of or atopic or serum IgE or skin prick test or specific IgE is positive in patients with eosinophilic asthma. However, the levels of IgE are variable, as well as some atopy in the form of skin prick test or specific IgE positivity may be seen also in eosinophilic asthma, particularly in the overlap group. Nasal polyposis is an important concomitant cardiac comorbidity in allergic comorbidity in eosinophilic asthma. And high FeNO and high eosinophil counts are common to both the types of type 2 severe asthma. And generally, the IgE is much higher in IgE specific or IgE mediated asthma. And eosinophils are much higher in eosinophilic asthma. But there is again a very significant overlap, which is very difficult to distinguish many times in clinical practice. But eosinophilic asthma is the one which is generally characterized by more symptoms and more exacerbations, because exacerbations are a direct marker of eosinophilic inflammation. And as I said in the previous slide, both types of asthma are oral corticosteroid responsive. When we looked at our severe asthma clinic and looked at 100 consecutive patients, we found that the IgE-mediated atopic asthma was seen in 36%, eosinophilic asthma in nearly 50%, and type 2 low asthma or non-type 2 severe asthma, in which it is not a type 2 inflammation, is seen in about 15% of patients. But very importantly, the overlapping features of IgE-mediated as well as eosinophilic-mediated asthma was seen in nearly about 1/3 of these patients, which is called as overlap group. So in such patients, patients are eligible for omalizumab as well as anti-IL-5 drugs, and two of them available are mepo and benralizumab in India. So you look at the eligibility criteria. If the IgE levels are very high or body weight is more than 150 kg, then we know that these patients are not a candidate for omalizumab. Your only choice is to use anti-IL-5 drugs. On the other hand, there are patients in whom you would see that the eosinophils are very high, and they are looking for a drug which can be used only every month or every other month. Then benralizumab is the choice, which after 3 months become every 2 months rather than every month. On the other hand, omalizumab needs to be given every 2 weeks to 4 weeks, because the dose is dependent on not only the serum IgE level, but also the body weight of the individual. When we look at the eligibility of biologicals in this 100 cohort of patients of severe asthma, more than 90% of the patients were eligible for one or more biologicals. And very importantly, 50% of these patients were eligible for both group of biologicals, that is anti-IgE as well as anti-IL-5 drugs. So that leads to a confusion in the mind of clinicians treating the patients of severe asthma with biologicals to choose either omalizumab or whether to choose an anti-IL-5 drug, and which also has now 2 drugs to confuse us further. Very important features of anti-IL-5 drugs, both benralizumab as well as mepolizumab, is that both of them are effective even if the patients have high serum IgE level and atopic status in the form of skin prick test being positive or specific IgE being positive in this group of patients. Similar data has been seen also with mepolizumab, that irrespective of the IgE level of the patient, whether it is high or is it low, so long as the eosinophils are high, mepolizumab is equally effective. So whether it is allergic or eosinophilic asthma, even mepolizumab works better or has been shown to be equally effective. So this consistent results of both the anti-IL-5 drugs makes us question the role of anti-IgE drugs, and that makes the situation more complex, particularly in the patients who are not clearly atopic but have overlapping features where eosinophilic features are also there, clinical as well as biomarker driven. So once we are into this kind of a confusion, then we start looking at the 5th touch point, which is the predictors of good response. So if a patient is childhood onset asthma with a clear-cut allergy-driven symptoms and a total IgE and weight within the range where you can use omalizumab, then this patient is showing the predictors of good response to use omalizumab, particularly if the FeNO is more than 19 in this group of patients. So we will choose omalizumab. On the other hand, if there is an adult onset asthma with high blood eosinophils and nasal polyposis with a lot of exacerbations in the last year, then these are the patients, they are more likely to be responsive to anti-IL-5 therapies, and you can choose between mepolizumab and benralizumab. If we look at the literature, what is recommended in this overlap group, because this overlap group is common to the word across, and they have very clearly mentioned you can use either biologic type and observe these patients, and if non-responsive, you have a choice to switch to the one which you have not used before. So this overlapping phenotype, which we have seen, is nearly to the tune of 30 to 50% in the various populations across the world, is the group which is eligible for all kind of biologicals, that is the anti-IgE as well as anti-IL-5 drugs. However, anti-IL-5 drugs are preferred over anti-IgE if the serum IgE levels is very high, which will increase the dose of omalizumab to a very high levels, or a very high blood eosinophil counts, where again the anti-IL-5s have shown to be very effective in controlling exacerbations and decreasing the dose of oral corticosteroids. However, the decision needs to be taken on case-to-case basis, and of course, don't lose heart if the patient doesn't respond to the biologic you have chosen, because failure of one, you can always consider switch to the other group, which is available now in India. And the last touch point is in the overlap group, where IgE as well as eosinophils seem to be playing a role in producing the disease in an individual patient, you need to be very careful to select what is called as a severe eosinophilic asthma, because this is the group which is going to respond to anti-eosinophilic drug, which is anti-IL-5, either mepolizumab or benralizumab. So to summarize the features of a severe eosinophilic asthma is adult onset, equal distribution between sexes, few to none allergies to common allergens, and chronic rhinosinusitis with nasal polyposis. These are the group of patients who are at risk of severe exacerbations, frequent asthma-related exacerbations, and accompanied by a low lung functions with persistent airflow limitations. When we look at their inflammatory features, they have elevated eosinophils in the blood, normal or elevated IgE levels, and may exhibit also aspirin sensitivity. But overall, everything taken together, this group of eosinophilic severe asthma patients responds very well to the oral corticosteroid as well as anti-IL-5 therapies. So in anti-IL-5 therapies, we have two drugs available: mepolizumab, which neutralizes the free circulating IL-5 in the blood, and benralizumab, which goes and attacks binds to the receptors of IL-5 on the eosinophils, and with the help of a natural killer cell recruitment leads to apoptosis of eosinophils and complete disappearance of eosinophils from the blood. But is one of them stronger than the other one? And this is a data which tried to look at it: benralizumab, mepolizumab, racilizumab, and even dupilumab. And it found that this data is mainly retrospective and unadjusted, and hence the effect size on improvement in lung function, steroid intake, asthma control, all may not be reliable. And RCTs versus real world experience may be totally different. However, there seems to be from the data no real big difference in reduction in exacerbations and improvement in all points on asthma control, whether you use mepolizumab or you use benralizumab. However, the data is more robust and more secure to point that the exacerbations are significantly reduced, perhaps more significantly reduced or better reduced by dupilumab and racilizumab. So when we are at the crossroads, we need to look for pointers of best response to an individual biologics, like omalizumab, childhood onset asthma with comorbidities of allergic rhinitis, chronic dermatitis, atopic dermatitis, and chronic idiopathic urticaria. Mepolizumab in corticosteroid-dependent asthma with comorbidities like sinusitis, nasal polyposis, or COPD. And benralizumab in adult onset asthmatic patients with comorbidities like nasal polyps, bronchiectasis, and smokers. And very important point to highlight is that despite omalizumab being used for 15 years, mepolizumab for 5 years, and nearly 4 years for benralizumab, no safety signal has come that these monoclonal antibodies can make antibodies against them in human beings and create problem, as it has been reported in rheumatology practice. But last point, very important, is that if one drug fails, there is enough data to suggest the other one can still work if the patient fits into that criteria. And those patients who had suboptimal response to omalizumab showed excellent response when they were shifted to mepolizumab. And even we have a data that those patients who have suboptimal response to mepolizumab did much better when they were shifted to benralizumab. So the cross or switch is still possible once you fail on one biologics in the patients of management of severe asthma. This is the care pathway which summarizes that you try to identify whether your patient is purely driven by allergy and IgE or eosinophils or the overlap group. And if they are into the pure groups of eosinophil or IgE, you have a clear choice to use either anti-eosinophilic or anti-IgE drug. But if you have an overlap group, then you need to identify that this patient is more towards the IgE, where the patients are young, allergic rhinitis, urticaria, atopy test very strongly positive, use omalizumab. If they are older people with IgE levels very high, they are using oral corticosteroids, they have nasal polyposis, you will use an anti-eosinophilic drug. And whether to choose mepolizumab or benralizumab, you need to look at the comorbidity profile as well as the burden of oral corticosteroid and exacerbations to choose between A or B. With that, I would like to thank you all that these are the 6 C's for choosing biologics in allergic asthma. Choose your right patient, choose your right reason, choose your right target, and choose to phenotype and endotype them with their allergic comorbidities, and then also the response as an endpoint. And of course, in the last, consider switch if everything else fails. Thank you very much.
Thank you, Dr. Talwar. We all know that biologicals are the new age drugs, and these monoclonal antibodies are the talk of any specialty, whether it's allergy or respiratory medicine or rheumatology or maybe any other metabolic diseases. So Dr. Talwar has so nicely, he has put on the facts which we need to see while starting a patient on any biological which are available in the Indian market. And so this has really cleared the mist which these drugs carries. Thank you very much, Dr. Talwar. So I think we can go to the question answer session. And Dr. Swanika, shall we proceed for the Q&A? Because we have little time left for that.
Yeah. So I think Dr. Raja has joined us. I suppose, Raja, are you there?
Yes.
I am there indeed.
Hi, Raja.
Yes.
Yeah. So welcome.
Hello. Welcome.
Hi. Thank you.
Okay.
Thank you.
So I think because we've already overshot our time, I think we can take some audience questions.
Yes.
If it is there, and I can see some on the board. For example, there is a question for you, Raja, that how many days we can give this fexofenadine in these cases of allergic rhinitis? One question that I can see is how long the fexofenadine can be used.
So Rajesh, I think I normally prescribe drugs like fexofenadine, so anti-allergics, for short periods of time when there is exacerbation of allergic rhinitis, so symptoms in the form of runny nose, blocked nose, sneezing, a bit of a dry cough. I would give it for somewhere between 7 to 14 days, and I would stop after. I would continue the intranasal steroids for longer. If the patient has got a combination of allergic rhinitis, asthma, I would continue the montelukast for longer. We need to remember the FDA black box warning for montelukast for psychiatric features at the moment. So we have cut down on the prescription of montelukast to an extent. However, I think it's safer continuing that compared to continuing fexofenadine for long term. So that's my sort of algorithm: 10 to 14 days when there's an exacerbation, but not beyond.
Yeah. So that's a problem, that they don't take it alone, but it's always combined with also montelukast, and they keep on getting hooked to it, and they just keep on taking it. So that's a point to be taken in fact, and also this what you call black box warning has come in the FDA now, also recently. Yes, Dr. Mahendra.
Yeah, I think the next question is for Dr. Narmada. Dr. Narmada, are you there?
Yeah, I'm here.
Yes.
Thank you for
Thank you. So, is sublingual immunotherapy really effective in sting bite allergy? And what is the standard protocol to treat sting bites reaction if we cannot identify the culprit insect? This is by Dr. Mehta.
Basically, I don't have any experience with regard to sublingual immunotherapy. I don't have any literatures also supporting that. So we have given only the subcutaneous immunotherapy, and we have literatures only supporting that. So I have not heard of anybody even doing the same. So this is maybe if you have an idea, you can enlighten this on the same.
No, you're absolutely right, Dr. Narmada. For the venom immunotherapy is the subcutaneous route. We only give the subcutaneous immunotherapy for the venom immunotherapy. And he has another question he has asked that to treat sting bites reaction if we cannot identify the culprit insect. See, for this, yes,
I think we have to find out the culprit insect. Otherwise, we cannot plan the immunotherapy, and then we cannot keep giving for 2 insects at a time also, which is not okay. So I think there are a lot of tests available apart from that. No, that the CRT is available, basophil test is available. Clinical history and serum-specific IgE determination is very essential for us to go ahead. So we need to identify the same.
Exactly. We have 2 parts in the treatment of the insect allergy. One is the pharmacotherapy and another is the immunotherapy, the venom immunotherapy. For the venom immunotherapy, you need to identify the culprit insect, and that has to be determined by the specific test or specific IgE. But nowadays we have this component-resolved diagnostics, which helps in identify that. And the pharmacotherapy protocol is the same. For the large local reaction, we treat it accordingly, and when anaphylaxis, we treat with the epinephrine.
Yeah, and maybe the history is there again. I will again reiterate that non-IgE immediate reactions are also there. So for which we don't think about this immunotherapy at all. So the kind of reaction, the type of, all this are mandatory. That is why so much of time was spent on identification, the treatment, the reaction part of it.
Okay, and
so can this insects can be also what we call source of inhalant allergens, because we have said about really what insects.
Yeah.
Well,
yes, sir.
I did. Source of inhalant allergens, like we see what we call cockroach and this thing. So can
mosquitoes are also said as an inhalant allergen, but then it will be too wider discussion for us to go across. And the inhalant allergy we usually discuss when we do the sensitization part of it, when we are trying to find out the aeroallergen sensitization. That is why I didn't touch upon that. I concentrated only on the insect venom hypersensitivity here. Definitely, there is a component here, and as you said, rightly said, cockroach has been implicated. In fact, all my the tests which I've done in allergy skin test have shown reaction to mosquitoes also. But then we need a high index of suspicion and correlation here. This is a very exhaustive topic for half an hour. I didn't want to push with my.
I think there was one question. The recommendation for omalizumab in urticaria with peripheral edema, family Stevetopi, if IG is between 145 to 158. This was for Dr. Zohar, right? So if we can answer this, so that is basically the treatment for omalizumab for urticaria. It is not guided by any family history of atopy or neither by the IgE level. Initially, we used to differentiate the urticaria into an autoallergic that is type 1 or an autoimmune that is type 2B. It no longer holds true these days. So basically, we say chronic spontaneous urticaria. And initially, we start with the treatment of second generation antihistamines, increase 4 times, and then we can add omalizumab. Peripheral edema, well, peripheral edema is a very vague thing. So if you are correlating with urticaria, maybe you mean to say that there is some angioedema component with there. But urticaria's angioedema is always has the histaminergic. The histamine is directed to that problem. So it is not the bradykinin one. So usually this is the plan. So so there is sublingual immunotherapy approved in India by Dr. Kota. So Dr. Narmada, would you like to say something on this?
Again, we don't have the approval for the same. We all know for the sublingual immunotherapy in India. So one-to-one consultation, you're clear, you talk with the patient only is going to help us, and it's a way forward. I think basically the reason why sublingual is not yet approved in India is because it's still with the drug control authority. It's here that the approval rules are quite different from what is there in the Western countries. So I think we need to change. The approval has to come through the pharmaceutical different guidelines so that we get it faster. But as of now, as of date, we don't have an approval for sublingual immunotherapy.
Okay. So there are no more questions in the chat box. So
So,
yes.
can I take
Yes.
a minute? So,
Yes.
Yeah,
so I
yes.
made a mistake. I made a mistake when I was
I was
speaking.
going to
So,
ask you that. Yeah, I was going to ask that, Rajesh.
so Rajesh pointed that out very kindly, inboxed me. So I'll just clarify. So slip of tongue, I'm sorry. So when we were speaking about particulate matter, I said millimeter rather than saying micron. So there's a lot of difference between millimeter and micron. So just to put things in context, when we talk about a 2.5 micron particulate matter, you understand that a sand particle has a diameter of 90 micron. A strand of hair has a diameter of 70 micron. So we are talking about very, very small particles, fine particles, which is why the question of going into the smaller airways, then getting absorbed in the bloodstream, and all of these features arise when you talk about air pollution. So just a clarification for the audience. I'm sorry if I confused people. We're talking about very small particles. We're talking 2.5 micron, 10 micron, and 1 micron, rather than the millimeter I mentioned. So apologies again.
Thank you, Rajesh. Thank you. So means I would like to
biomarkers. I like to ask actually also Dr. Deepak Talwar about this predictive biomarkers, because people are increasingly going towards personalized medicine in asthma. So how does it help to have this predictive biomarkers when you use biologicals in asthma?
So Rajesh, at the moment, the markers are only telling us that it is a type 2 inflammation. So whether the patient is going to respond to anti-IgE or it is going to respond more to benralizumab or mepolizumab, it's very difficult to predict them. But yes, one way or the other, when we look at it, the specific IgE as well as the skin prick test, which is strongly positive to allergen, to which we can clinically correlate, is a good biomarker for an anti-IgE therapy. Again, a very good marker for a biomarker for using an anti-eosinophilic drug, which is either mepolizumab or benralizumab. But I think the clinical scenario is perhaps a very important aspect which needs to be incorporated into the workup of the patient, as biomarkers alone may be overlapping and might lead to some amount of a confusion. FeNO is the one, actually a biomarker which we very commonly use, but what it tells us is that there is a type 2 inflammation. It does not tell us that that's going to be effective, because the only drug in which it has been correlated is dupilumab, which is anti-IL-4-13, because primarily FeNO is a driver of an IL-13 a cytokine and not IL-5. And IL-13 is targeted by dupilumab because it shares its alpha subunit receptor with the IL-4, which is blocked by dupilumab. So that is still not available with us. So all this said and done, we just get pointers. We don't get a very clear-cut clear-cut yes or no with a biomarker to tell us that single biomarker to tell us that you can use A or you can use B or you can use C.
Thank you, Deepak, for clarifying on that. We are shooting our time. I mean, do you have other questions? Otherwise, we can wrap it up.
I think one last question, Raji. I would just like to ask you that you take one particular aspect. As we all know that the allergic diseases, its prevalence is increasing globally, and we know that the air quality standards are also deteriorating. It is in most of the cities, especially in the low medium income countries like India. So what do you say about this increasing air pollution and increase in the allergic diseases?
So I think, yeah, sure. So I'll give you a general answer, and I'll also maybe ask you about your thoughts on this. So I think we understand that in India, allergic rhinitis is an extremely prevalent disease, as it is globally. We have data from the eastern part of India, which we have published, which shows that the incidence of allergic disease probably far beyond the 5 to 8% that is quoted in the literature. So for us, it's probably more like 15 to 20% of the general population having some degree of seasonal allergic rhinitis. Now, air quality indices are very poor in India. We have 9 of the most 10 polluted cities in the world. So we understand that air pollution is also one of the most important triggers, or the most important trigger for allergic disease, especially allergic rhinitis and asthma. So if you add these two together, it's a huge problem. And I think people like yourself, so pulmonologists generally, who look at allergic disease, who have respiratory disease, need to keep this in the background, that a lot of the asthma they see, a lot of the COPD they see, even a lot of the other chronic diseases like ILD they see, would be compounded by allergic rhinitis. And while there is good literature available about concomitant asthma and allergic rhinitis, there's not so much of literature available about concomitant COPD allergic rhinitis, or almost no data about ILD and allergic rhinitis, and we don't know what it does to the airways. We get these patients with ILD who have high eosinophils, and I don't think we actually know what it means in this particular scenario. So I think for us who treat allergic disease, who treat airways disease and chronic lung disease, allergic rhinitis is a disease process that we will see often, and to treat it is important, not just because of the allergic rhinitis part, but also to control the background chronic lung disease that these people have. So I think that's something which we need to keep in the background when we treat these people.
Yes. Do we also need to streamline diagnosis of allergic rhinitis now that you have said that there's a huge burden in India? Or are we just happy with the American guidelines that we follow for this allergic rhinitis?
No, I think it's important that people like us and ENT doctors join hands to create an allergic rhinitis registry when we look at our patients. I think we cannot be happy just with certain pockets of the country generating data about allergic rhinitis. I think we need an all-India database for allergic rhinitis. We need to look at concomitant disease. We need to find out how common it actually is. And we probably also need to look at PM 2.5 values and the amount of allergic rhinitis exacerbations that people have. If we have that data, we'll probably be able to put this in clinical context and go ahead and treat these patients on a regular basis. I mean, people think asthma is a serious disease. They think COPD is a serious disease, but allergic rhinitis is just another runny nose, a bit of sneezing and wet handkerchiefs. That's what it is about. And I think it needs to enter into people's conscience and the medical fraternity's conscience that this is a disease that needs to be treated and controlled. And only then will we get a handle on diseases like asthma.
I think Indian guidelines on allergic rhinitis is very much needed. Maybe Indian Society can take it as a
absolutely
for the guidelines. We can involve ENT, as you said, and other who are also stakeholders in this, and we can have these Indian guidelines. Thank you, Raja.
Thank you. Yeah, so I think in that this ends this today's evening in webinar number 3 on this webinar series of allergy and immunotherapy. I once again thank all the faculties who joined today's evening, Dr. Narmada, Dr. Zohar, Dr. Rajadhar, and Dr. Deepak Talwar. And obviously, a special thanks to Dr. Swanakar, who actually moderated the entire event so beautifully and made it a success. And definitely, it means I don't want to leave any stone unturned. So a special thanks to Sanofi, who has actually sponsored the program. And obviously the Indian Society, under whose flagship this entire series saw the light of the day. So thank you everyone, and good night. So we will just wait for the last part of this webinar web series, that is the series number 4, where we'll be discussing mainly on the immunotherapy and the other aspects of the environmental control in reducing the allergic diseases. Thank you very much.
We have some dates for that, Maitra, so we can announce it. Do you have some dates? And
it's tentatively we'll have it in the middle of June, somewhere in the middle of the June. So we'll just finalize it, maybe around 15th of June.
Okay, so thank you, Dr. Moitra, and we got some feedback also survey. So because when you exit, please also do this feedback survey for us so that we know the feedback and we can improve on things if you like. So do also remember to have this feedback survey done by all the audience. Thank you, Dr. Moitra. Thank you for being there. Thank you, Raja. Okay, thank you, Raja.
Thank you, everyone.
Bye, Deepak. Bye. Thank you, Dr. Narmada.